we're gonna go into our ACL surgery video demonstration.
One more time for our panelists. One more time, give it to them. That was good. Okay, fair warning, surgical pictures. Everybody okay? All right, cool. Let's talk about most common knee injury. Keep going. Okay, so I'm big about vocab, breaking it down. To understand the pieces, you gotta know the pieces of the puzzle, right? ACL, anterior cruciate ligament. Now, if we're looking inside a knee from the front, okay, you got a few different ligaments. I'm gonna roll with this. There it is. Looking at a knee from the front, all right, you have ligaments in the front and the back. ACL's in the front, PCL's behind it. It's not usually green, but you have articular cartilage in your joint. That's kind of like the bearing surface that keeps it from, having bone on bone, so to speak, right? This is basic for some of y'all, but review is good. The MCL's ligament on the inside of the knee and keeps your knee from going outwards. On the outside, you have the LCL, it keeps your knee from going inwards. The meniscus is in between, that's purple here, not usually, but here it is. It's like a shock pad in between the joint, once again, keep you from being bone on bone. So you gotta know the components so you can go into the next steps. Go ahead. Another word I like to break down a lot, arthroscope. So you hear the term knee scope, shoulder scope, hip scope. People just say scope this, scope that. What are they talking about? Is that even a surgery? So let's break it down to the pieces. Arthroscope. Arthroscopic surgery, arthro, referring to joints, scope referring to the camera. So an arthroscopic surgery is when you're doing surgery via a tiny little camera in the joint. Basic enough, right? Here's a picture of said arthroscope. And if you want to see it live and living cover, we got it right there in the back with Shermer Francis and with Sam Bowman. If you want to show your skills with it, you have a chance to do that too. It's like playing a video game, and you'll see soon, okay? So if we're treating an ACL, the most common way to treat it, if one is having surgery, is an ACL reconstruction. So that reconstruction refers to building a new ACL rather than just putting it back together. Let's do the next slide. Stuck. Oh, there it goes. All right. So we've confirmed that someone has torn their ACL. Once again, that ligament in the front that keeps your tibia, your shin bone from sliding forward. The ACL is torn. There's a picture of one that's torn. Next slide. So to reconstruct an ACL, what we're doing is we're actually drilling tunnels into the femur, the thigh bone, and into the tibia down below. Next slide. And through those tunnels, we're going to put a graft or a new ligament through there. So that graft can be from you, that graft can be from somebody else, from a cadaver. Let's go next slide. Okay, last chance. No, you're good. You're good. All right, let's go. Can y'all see that? That's all right? Okay, we're looking inside the knee joint right now. Okay, so on the inside of the joint, up above, you see that smooth kind of pearly surface? That's the cartilage. So that's how cartilage should look like if there's no arthritis, a nice smooth surface. You also have the meniscus, kind of the shock pad in between. Now, if we go over here, this was an ACL. So this person is missing their ACL, they've torn it out. And you see the empty wall there is where the ACL should be sticking. So they've torn it completely. There's the PCL for reference. See how I can't put my pro back behind it? So we've confirmed that we have an ACL tear. And don't worry, we're gonna run this back. I know it's going fast. We've confirmed we have an ACL tear, so we know we're gonna do the next step, which is do what? To reconstruct it, right? So when we're doing that, and once again, we're using tiny little instruments in the camera. So while this looks big on your screen, everything here is tiny, just like you see back there if you take a venture. Oh, we froze. So here I'm using a special little instrument called a radio frequency ablation device. It's almost like a lightsaber, if you want. It creates a plasma field that breaks down the tissue. So I'm removing scar tissue, or I would be if it wasn't stuck, removing scar tissue where the ACL used to be. And as soon as it gets going again, I'll show you. Any questions so far? Clear as mud? That's okay. So we're back in the joint again. I told you to come back one more time. So joint surface for this person looks excellent. You see this cartilage? Like a baby's bottom. Right here on the tibia, beautiful, gorgeous, all right? The meniscus in between, beautiful shock pads. Don't need to be replaced, nothing like that. This person's knee is pristine, okay? And we always do what's called a diagnostic arthroscopy when we start any surgery. So we go and we check everything out and we see what's what before we start doing any work that's irreversible, right? And in a second, we're gonna move into where the ACL is in the middle of the knee. No, you're good, we'll just let it play. It's not that long, thank you. All right, should be a big, thick ligament going right there into that bone, that ACL. Instead, you have a bunch of scar tissue in the way. We call that the empty wall sign. Look on the other side, you see the PCL? I can't put my probe through there. So the PCL is fine for this patient. That's the comparison, okay? So we've confirmed via our diagnostic arthroscopy, all right, that the ACL is torn. So now we're gonna make the next move and make our tunnels. So the lightsaber is here. I'm using it to clean up that old scar tissue, get out of the way so I can find the spot where the ACL should be. So very important, if we're doing surgery, we want things to be anatomic. What does that mean? You wanna put it back where it was put before. So I'm trying to find the footprint of the ACL where it originally was, and that's where I'm gonna put my tunnels so that it matches up. I'm not gonna put it just nowhere, I'm gonna put it where it's supposed to be. So now I'm doing that process right now. I'm cleaning it up. Now I use a special burr, it's kind of like a rotor that kind of smooths out the bone and cleans out the area once again, get that scar tissue out the way, and I can find the spot where the ACL is, and that's way back around there. So we're cleaning up. And again, small instruments, I got a tiny camera in my hand. Again, I'm playing a first-person video game. So we're gonna start drilling now. So we usually use tiny little pins to help guide our drill so that we know where it's going and we always control where it's at. So we're drilling this now into the bone of the femur, making our femoral tunnel. You see those little numbers on there? So I can actually measure for each patient the size of their tunnel. So everything is patient specific. So if your tunnel needs to be 20, yours is 20, and I know that. It needs to be 15, it's 15. So it's not one size fits all, everybody's different. So we set that, we then set our drill in place, and we start our drilling. And we start drilling, okay? So notice how there's all this bone dust in there? We don't want that in there, so we're gonna get rid of that here. So we use our little rotor machine again, we'll clean that out, and now we have a nice tunnel. It's just like the picture I'm about to show you again. You see that tunnel into the femur? We now made our femoral tunnel on the thigh bone side, okay? So clean all that bone dust, let that rotor go. We're gonna do the same thing on the tibia, the shin bone side, okay? So top and bottom, drill a tunnel. This is a little guide that's gonna help us get our pin in the right place to drill the tunnel. Exact same process, just at the bottom. You'll see it in 1 second here. There it is. So there's our pin. That pin's gonna help us drill our tunnel up. Wild, right? Yeah. Let's give it a second. We always check to make sure we like the spot that the pin is before we buy it, so to speak. So now this patient has both a femoral up top tunnel and a tibial tunnel. So we take the graft, the new ACL prepared by Sherma Francis, round of applause. And there it is, there's that bone piece on the patella, you see that? There's that piece of bone attached to the soft tissue of the ACL. We're literally gonna pull it into place in just 2 seconds. Oh yeah. Brand new ACL. No more empty wall sign, right? Can't see back there. The ACL is rock solid. To make sure that's true, we're gonna put this little plastic screw. I use plastic screws. Some people use metal screws. Choose your poison. I don't want metal in patients' bodies personally. I don't like it. So I use these non-absorbable plastic screws. If you have questions about that, Mr. Sam Bowman can walk you through that right here, his product. All right, so now we have an ACL, a patella tendon graft in this patient's case. Here I am checking it to make sure I like it, pulling on it, giving it a nice little massage. Beautiful. Questions? So the question was, what if you don't split your ACL all the way through? What if you just tear it off the bone? Can you just put it back in place? That's called the ACL repair versus a reconstruction. It's controversial. All right. So rather than splitting it through the middle, If you tear it off the bone, some people suppose that, well, you can just stick it back on. And there's some pros and cons about that. It works in some patients very selectively. There's some newer studies coming out with a new implant. It's called a Bear implant, for example, that uses kind of a combination of collagen, the stuff that makes up your tendons, to mix in with that and stick it back into the bone, and hopefully that heals. That's new, semi-experimental, so it's not necessarily the gold standard, but it has promise. So it's possible in some cases, but we're still learning. Anything else? That's a great question. The question was, why use plastic instead of metal screws? I don't like metal personally because I don't want pieces of metal inside of people for a variety of reasons. I don't want you to have to worry about the airport. I don't want you to worry about getting an MRI later in life. I just don't like the idea of it. Sometimes it's not so scientific. Now, the plastic screws are technically called PEEK, and they're non-reactive with the body. So your body's gonna have much less reaction to that compared to metal. And so I'm trying to leave as little impact as I can on the patient whenever I'm doing a surgery on them. So whatever's gonna, cause them the least problem later is what I'm gonna do. Yeah. That's a great question. So how do you choose the size of the tunnels? And so it's a combination of the patient's anatomy. And so based on me having looked at the MRI beforehand, I'll measure what I think they're gonna be. And of course, we do our diagnostic arthroscopy, and we check it out, and I make sure the sizing makes sense. And so a combination of that and the size of the graft that they have is how I decide. Good question. Not too commonly. So the question was about PCLs versus ACLs. PCL's back there in the blue, ACL in front of the red, right? PCL tends to be a stronger ligament, so it's harder to tear it. Also tends to heal itself better than the ACL for reasons we don't fully understand. So it's pretty uncommon to have to do surgery for a PCL, but it does happen. Usually higher energy stuff, football injury, tackle, car accident, that sort of thing. Yeah. So why are we seeing more ACL injuries? And at a younger age too, right? It's wild. I agree. It's an epidemic, really. And if you think about the long-term consequences of getting arthritis later in life, it's a big deal to have an ACL early in life. We didn't hear about it when we were younger. So it's a combination. I think some of some of our peers maybe had ACLs we didn't know about. That's one thing. But I think kids are starting sports so much earlier and specializing so soon that they're at increased risk for injury. And that part is the epidemic part. That's what we have to kind of preach. That's why that panel we just had before me was so much more important, even though I had videos, than what I had to say. Because really, we don't want to have you have an ACL tear in the first place. And that's a combination of, like we talked about, strength, mental health, but also not super specializing and playing the same sport year round off the bat at such a young age. That's why my man here is playing basketball, soccer, and doing some jumping around, right? You gotta have free play too, right? All right. Anything else? All right, yeah, there.
How often are you dissuading patients from pursuing ACL reconstruction? Like, how often are you encouraging conservative management of an operation?
That's a great question. So it's all about, the question was, how often do you tell a patient, maybe we don't need to do surgery, basically, right? So it's about your functional goals and what you do. So the ACL is critical to what activity would you say, or types of activities? So I'm gonna throw it back.
Anything that requires a high level of cutting.
Exactly. So the first question I'm gonna ask you as a patient is, do you need to cut and pivot? Because if you need to walk and run in a straight line, you don't need an ACL, really. So you have to ask yourself that question. So I break down that I'm gonna drill tunnels into their tibia and femur and make them do rehab for a year. And I say, is what you wanna do worth going through what I just proposed to you for your life? Now, if you're a college athlete, the answer is yes. It's just that simple. If you play soccer and you could stop and just weight train and run and do marathons, half marathons, whatever, moving forward, maybe you don't need ACL. Now that changes if you're having instability, like your knees like giving way just day to day. If your knees giving way just day to day with life, going to the grocery store, going outside, we can't have that. So in that case, we're talking more surgery. But if you can rehab and build the muscles, those lighthouse muscles around your knee, and that makes your knee stable enough, then don't do surgery, do that. I think Jen had one, and then.
How does like a subsequent meniscal injury impact how you handle surgery and then impact the patient's recovery?
Just to clarify, so if they had a meniscus surgery when I got in, there was a tear, or later?
Like if they have an ACL and a meniscus.
Yeah, so the meniscus, again, that shock pad that was good for this patient. If you tear that at the same time as the ACL, which happens not infrequently, that slows down your rehab in the beginning. It also increases the arthritis risk, unfortunately. And so, to your second point though, we don't want you having a second ACL injury too. Because let's say you got by on the meniscus on the first one, but you have another one later. You tear that meniscus, you now have a secondary risk for arthritis. And so that's where the key of rehab after and before is so important.
So LETs are like a big deal in Europe. What are the factors you decide? What decision you make to decide on an LET for a patient?
This is a board exam? Golly. All right, LET, lateral extra-articular tenodesis, that extra tightening on the outside to stop rotational instability, LET for short. My indication for an LET is most of the time, if you've had an ACL before, a lot of times the reason why you tore it again has to do with that rotation. So I'm gonna add the LET to give you a backup to keep you from re-tearing. Two, if you're someone who has a lot of rotational instability from jump street. So if I take your knee and I examine it, and your pivot shift is over a grade 2, along with your Lockman, I'm sorry, this technical details. Then I'm thinking LET on top of your ACL primarily. If you have a lot of laxity in your knee naturally, Ehlers-Danlos, hypermobility, whatever, what have you, collagen disorder, then we're gonna have the discussion. I'm not gonna make you do it, but we'll discuss maybe we should add that to give you some more stability. Good enough?
How does that LET then affect your rehab afterwards?
For me personally, it doesn't. It doesn't change my protocol. So the first thing I want to do is get your quadriceps activated. Quad control, quad control, quad control. That doesn't change that for me. For the patient, I've noticed that it might make it slower for them in the beginning because it's more surgery, so they hurt more. And so it's harder for them to activate that quad muscle. But in terms of the protocol, like progressing you, it doesn't change it for me. Yeah, absolutely. So the question is about your alignment overall, rotational alignment of your femur, your tibia. Exactly right. So I think that's a big thing, especially if it's a re-injury. So if we're talking about a re-tear of the ACL, you need to prove to me and the patient, why did you re-tear your ACL? Did you re-tear it because you just got hit? Then that's circumstance. Is it because you have something different about your alignment of your bone, how your bones line up? Maybe that needs to be addressed, to Dr. Dodd's point. If it's a situation where you have too much tibial slope, it's another reason. So if the way that your shin bone, your tibia is sloped such that it pushes your tibia forward, sometimes that has to be addressed with an osteotomy. So that's something we're gonna look at if you're coming back. You know, we'll look at your rotational alignment, your standing alignment, to see what needs to be done, if anything else. That's a great question. So do we fix the meniscus or do we remove it, or at least partially? Can you go to the video? The video will help you. There you go. I got time. All right, so that shock pad in the knee. So you want to have a shock pad in your knee, very important. All right, we don't want to take that away. And so it's only a last resort in which we take that meniscus out. Now, that wasn't always true. There was a time in surgery we thought you didn't need that, like your appendix, which also wasn't true. You need everything in your body. So if you tear your meniscus, the number one thing I'm trying to do is save your meniscus. And so plan A, B, and C is to fix it. And that's put stitches in it and put it back together. Now, sometimes it's torn in such a way, you can pause the video. Sometimes it's torn in such a way that fixing it just doesn't make sense. For instance, it doesn't have good blood flow or it's too torn up to hold stitches. If there's no blood and I stitch as pretty as I want, it's not gonna heal. It don't matter. So I can't control that part. In that case, we might think about doing a partial meniscectomy, which is taking just a little bit of the meniscus out so it doesn't keep on catching and causing you a problem. All right, I think we gotta move on to the next panel. All right, I appreciate y'all's attention.